Thank you very much, everybody. So I really start with two premises. The first one being that every patient should have a dedicated electronic healthcare record. That's particularly important for people with conditions such as Lynch. And the second is that the person that should be helping to lead that care record and the patient's care is the patient themselves. And this is all very much in keeping with 4P medicine for 21st century healthcare, which is if we can start to integrate care records with patient outcomes, we might be able to make better predictions. And from that you can personalise and hopefully you can prevent problems from occurring. But that does not work unless we're involved in the fourth P, which is crucial, which is participatory. And it's crucial that we work together, and it's a huge honour and a privilege to be here today and to be working with Lynch Syndrome UK and colleagues in developing this work. So the first thing that we did is we worked with Ipsos Mori. You may know Mori from the political surveys that they do, but they're very keen to get involved in healthcare research and have been incredibly helpful. And we linked with Instant Access Medical, who have an electronic patient care record for children with special needs getting involved in the Special Olympics. So they already have a GP record, and they very much bought in to those two pillars principles that I mentioned. And with Ipsos Mori, we reached out to Lynch Syndrome UK and to Tracy, and it's a huge thanks for the work that Tracy did in helping to speak to patients about what was important to them and the challenges that they had. And we asked 106 people with Lynch syndrome, a number of which are probably in this room, so huge thank you if you took part, to find out what was important to them as we started to think about a dedicated electronic healthcare record. And what was important was access to information, not just for themselves and their family, but also crucially their GP. We've run what are called medical supermarket events in the past, where we have one or two talks, but then you can go down the aisles and speak to a dietitian, a physio, a psychologist, clinical genetics counselling, and pick up all the information you need. And we're going to be running some of these events for Lynch syndrome. And what was key when you speak to patients is that the key barrier seems to be, at all points, access through primary care. And that is through making a diagnosis, medical diagnosis, linking through, not just through to genetic testing, but even for family members. They still struggle even when a gene change is identified. The number of times I've had women come to see me, for instance, with BRCA, and they've been told, you don't need to worry about that, it's on your dad's side. And then they present with metastatic cancer. So this, I'm not here to bash GPs because it's not at all easy when you're dealing with thousands of conditions and we've got 25 patients outside wanting to be seen. But what I'm saying is we can't truly just rely on clinicians. We need to work together. It's that participatory aspect. So there's a number of aspects here which are important for patients. And in fact, even the 10th was over 80% were keen to actually still reach out and have additional information. And sort of challenges that were coming up were having a dedicated Lynch syndrome champion, someone that I can talk to, that was mentioned earlier, and that really was number one. And that sort of thing is certainly going to be improved when we think about these Lynch syndrome gene hubs. So I'm confident that people will feel as if they've got somebody to turn to in the future. So that is improving, and the resources for Lynch syndrome actually, compared to a lot of conditions, is actually in a pretty good position now. One of the other big challenges was the getting the diagnostic pathway right to identify patients and to make sure that they and their family receive the report, the support that they need, and signposting to organisations such as Lynch Syndrome UK. But also there's information about communication between the clinicians that you're seeing. So I worked with Stan Shepherd from Instant Access Medical and started to develop this self-navigation guide, and we're keeping it very simple to start with. So this is patient entered. So the individual can enter this information, and it's co-created with Lynch syndrome patients. And it's not here to take away the need for a clinician to be involved, but it's about working together, taking into consideration that there are limitations as Sir John mentioned, with the NHS, but can we work together so we get a very clear overview of a care record, but also add in opportunities for improved information about research and updates in Lynch syndrome UK, but also add opportunities for audit, because a big issue in clinical genetics is what constitutes good practice and what does constitute care for Lynch syndrome. Now, a lot of doctors are quite visual learners. You know, if you're a visual learner, if everyone takes their hand like this, puts it up in the air like this, everyone does that now very quickly, and place it very quickly now onto your chin. Now, if you're the sort of person that does that, my favourite, the slider, you're a visual learner, so you might quite like the dashboard. So the idea really, if you go straight to the dashboard here, you can see bowel screening, taking aspirin, Helicobacter, cascading information, gynae review, symptom awareness. It's a red, amber, green system, so it's a 3-2-1 scoring system. So across those 6 areas, you've got a score out of 18. So if your bowel screening is in date within the last 2 years, you'd score 3 points. If you've had bowel screening but it's not up to date, you'd score 2, and 1 if you've not had that. So the idea being you get a score out of 18. And the idea being that in 3 seconds, because my view with a GP, if you've not got the answer in under 30 seconds, you're nowhere. You've got maximum of 30 seconds. Okay, so these answers need to be right there, right when you need them. So the idea being that you will have a clinical dashboard, but it also does a letter for your GP, information for your GP, and all the other things that I've talked about as well. But it will act as a reminder, and the aim is to link this with the national database in time for your bowel screening and giving you updates, as well as links to information, for instance, for patient decision aids, and Kelly will be talking about that later. And we're not here to take over Lynch syndrome at all. That's not our role here. So if, in the longer run, I can see actually this being led by Lynch syndrome UK. What we're here is an exemplar principle of a dedicated and personalised care record, which will be there for the patient. But we also want to go much further. So here you can see we've got red flag symptom checkers, and you can see some of the ways in which you could self-navigate through this system. So what we want to do is to be able to roll this out to everybody. So we're linked in with Ipsos Mori, and we're taking on advice from patients who are saying, well, how about this? This doesn't quite work for us. So that's going on at the moment. It's been released to the first 25. We've now got activation codes for 2,000 patients, and we will be releasing that locally, but I'm very keen to release some activation codes to Lynch syndrome UK if people want to be involved. The aim is that this will go out on the App Store in May. So if people want to download this, then they need activation codes, because there'll be a play version that people can just have a mess about with, but we don't want that to get in the way of the actual data coming out of it. So there'll be a patient activation code, and then we'll be able to see how people are getting on with their clinical dashboard score. Does it change? In time, we'll be able to see if that links to a patient outcome. And if it doesn't change and people are struggling, we're going to be asking them with Ipsos Mori why and what are the challenges. Of course, we're dependent on people wanting to download this and to use it, but we're very mindful of the fact that it will be a reminder on people's phones that they've got Lynch. That might be a blessing, that might be something that some people find a challenge, and we need to learn that. So this is very much working together. So we'd be delighted to invite people for one of our medical supermarket events regarding Lynch syndrome over in Leicester, along the Golden Corridor of the Midlands. But also be delighted to offer activation codes as well if people want to take part. From here, we want to be able to link to other conditions. So von Hippel-Lindau syndrome is quite a similar condition, and we've got plans to potentially do that, but also linking in with P10. There's a lot of interest in the P10 international community for developing this and access into research. But we'll also see the potential of linking into pharmacogenetics. We know that's a feature for bowel cancer patients who have Lynch syndrome, who need to have a pharmacogenetic test to see if they can be given the right drug at the right dose, first time, every time. We want to get to the point where we're screening based on risk, not age alone. and we can see a point where you could end up going into Boots, other pharmacies are available, and with a QR code, make sure that your prescription for painkiller or blood pressure pill is at the right dose for you, so you don't get side effects or get less of them, and also make sure your drug works as well, because that's a major issue. And I think this is the key actually to breaking through with genomic medicine. But we're going to develop that slowly in time, but building from Lynch. We have a demonstration of a pharmacogenetic app if you want to see it. That's something that we could share with you, but we're now in a position where we've got this technically to work, but it's going to take some implementation. But the problem with pharmacogenetics is that you may not be taking a drug for actually 10 or 15 years. So we need solutions which will be future-proof for patients. But the idea is, I think, in 15 years, we'll look back at giving everyone the same drug at the same dose and think it was like leeches. And this is the secret to bringing in genomic and personalised and predictive medicine. We are harming too many people at present, but we're using Lynch syndrome as the way to help guide that moving forward. So we can certainly make sure on a red, amber, green system that people with Lynch syndrome will be able to get their right drug, and starting with the testing specific for Lynch, but moving on as well. Because we know that genetics isn't purely about whether or not trying to understand the reason why someone's got a disease in their family. It's about the two other R's, risk, but also predicting response to treatment. It's reason, risk, response. Clinical genetics, I say, is like stargazing. Stargazing is looking into the past, but when you want to think about predicting the future, genetics is not so good. And what you want to do is to do crystal ball gazing, and that comes from linking DNA results together, but also with other things. So your DNA code is only as good as predicting the future as your postcode, and it's linking different information sets that will make the key. Now for us, this is part of a very big program of outreach and engagement and co-creation work, from looking at things like disparities for bowel cancer to school children, and we've written a book looking at things like what came first, chicken or the egg, why do I hate Brussels sprouts, why is my hair ginger, and are you 50% a mushroom, why do they put blue in a traffic light? If you don't know the answers to any of those questions, let me know. And just to say that we're linked in, this is an NHS audit project which is registered, but we're linked in with the Code of Practice with Ipsos Mori. And just to say, I'm at the barrier between you and lunch, which is not a great idea. So I'll stay around for a while. Thank you for bearing with me. And thank you so much for Lynch Syndrome UK and for all of their support. And also to my clinical colleagues who have been supporting this. Thank you.
Thank you.